Yeah. Oh, good. Okay. So thank you very much for the invite. I'm going to talk about our music therapy for bereavement work that I co-lead with my colleague Lisa, who's going to be up next. And to get straight in, because I know time is short, but I think we could all agree that music is universal. Music plays such an important role in our lives, and especially at challenging times, and we don't have to think too far in the distance to remember the images that we saw of those out on their balconies in Italy, singing, playing instruments for neighbours and communities, and how that brought comfort to people. And even looking at the popular music, we can see how, again, music has been used as bereavement support. So it's just an example of some of the artists who have used music and songwriting as part of their bereavement and grief process to help them. So when we turn our attention then to bereavement support, the international guidelines advocate for a public health approach. A core outcome set for bereavement interventions includes ability to cope, mental well-being, and there is a need to stop or avoid pathologising grief, okay, and see how we can build this resilience-based approach instead. But currently, the research evidence, we still don't know what is the best model of bereavement support. So we need more evidence and we need better quality evidence. And this led Lisa and myself to explore, okay, is this an opportunity for music therapy to do its thing? So we began the Music Carer project. I still struggle how to say that, Music Carer. And we would encourage you to check out the website to find out more or contact us after for more information. But this was funded by the Music Therapy Charity. And I'm going to talk about the first phase of this work, the systematic literature review. So we looked at the international evidence that was across 6 databases. We used the Joanna Briggs Institute method, and we mapped the findings to that core outcome set for bereavement support and also to predictors of complicated grief. In terms of an overview, we found 34 studies, mostly qualitative, only 2 randomised controlled trials. In terms of informal carers, it was mostly those caring for those with dementia. And if you look at the intervention timing, you can see it was mostly this pre-bereavement phase. And again, that reflects the populations who were studied. So when we talk about pre-bereavement, when folk have those chronic life-limiting conditions, very often the carers, they start grieving that person long before the actual bereavement. So that's why we mean pre-bereavement support. In terms of the quality of the evidence that we looked at, the qualitative studies were moderate to high quality. The quantitative studies, low to moderate. And again, that was because of a number of methodological difficulties with doing the quantitative studies in this area. The most commonly targeted outcomes included quality of life and mental well-being. But the findings were mixed in terms of the quantitative research. Some studies showed improvements, some studies showed no difference, and some actually showed worsening of symptoms. And we could potentially attribute this to the difficulty with methods and the fact that it was quite low quality research. When we look at the qualitative research, that's where the gold is, okay? So we mapped this against the risk and protective factors, and this is where I have to put my glasses on. So you can see here on the right, the qualitative findings, the mechanisms of change, so what we think music therapy was doing to actually help with improve or protect against these risk factors and create those protective factors. So looking at bereavement, depression and anxiety, I hope you can hear me okay when I turn around here, but you can see that social connectedness and support is something that happened when music therapy was delivered as part of a group. The folk within these studies reported that creating that sense of belonging and reduced feelings of loneliness that we know can really heighten the bereavement experience. And it also brought about relaxation, calmness, and an inner peace. So again, those spiritual things that music really touches, but other interventions struggle to hit. And then looking at poor perceived social support, again, it was about fostering that solidarity. Being with people who knew what you were going through brought more comfort as well. Created that safe space to share feelings and receive social support. But what's missing in this here is the role of the music therapist was absolutely crucial. Because without the music therapist to help create these mechanisms, it was just music. And I'm not saying just music is not beneficial in and of itself, it is. But the music therapist knows what the clinical goals are for those involved in the music therapy and creates an environment where they can bring about the clinical outcomes that they want. Okay? Early non-acceptance of loss, denial, again, helping that relationship completion, helping folk communicate things that they may not be able to. And you'll very often hear from me afterwards, I wish I had said such and such. I wish I had told them, loved them. Music creates a communication channel to be able to do that. And then higher spirituality, again, bringing that sense of meaning, creating something together, bringing joy and helping, again, this thing about reconnecting and finding hope in something beyond the bereavement experience. So crucial. And then in terms of family conflict at end of life and difficulty remembering positive memories, again, music therapy as a shared activity helped improve those relationships and brought about positive memories. Oh. So in terms of recommendations, we need music therapy interventions specifically developed for bereavement support. We can see from the qualitative research evidence that there's impact on a broad range of outcomes that we need to be looking at for bereavement support specifically and help and protect against that complicated grief. And we need to evidence this with high quality trials. So that is what myself and Lisa are working toward. But please do keep in touch. Check out the website, come speak to us after, or email us. We would be so delighted to speak with you, and thank you so much. Let's check. Oh.
Excellent. So, hello everyone. I'm delighted to be here today and in such good company. In this short presentation, I'm really hoping to place a focus on assessment of psychological needs. So I think quite often as researchers, and I very much count myself in this, we can get very excited about the psychological support end of things, but we need to maintain that focus really in terms of understanding what an individual's psychological needs are. And it's only through that understanding and an evidence-based approach to understanding both level and nature of distress that we can ensure that people receive the appropriate support. So the research that I'm briefly going to be referring today to is this particular paper here. This was a study that was conducted a few years ago. It was in collaboration with Marie Curie Hospice Belfast, and you can see my co-authors listed there. To say this is published in Palliative Medicine Journal, it's open access, but any issues finding it, just drop me an email and I will send you a copy. So when we're talking about psychological needs, obviously psychological distress is key to that. And we understand that to very much exist on a continuum from, at one side, the very normal levels of distress that one might expect with any diagnosis, and certainly along that journey with advanced cancer or advanced illness. And then to the other side of the spectrum, or the continuum, we have more moderate to severe forms of psychological distress that might be indicative of mood disorders such as anxiety or depression. And you can see here from the prevalence figures that this represents a minority, but a sizable minority for individuals with advanced illness. And when we're screening for psychological distress, and by screening I mean the use of formal distress screening tools, so that falls under that larger category of outcome measures. When we're screening for psychological distress, we're really interested in distress at all sides, all ends of that continuum. And that's really so that we can provide the appropriate support, whether it is internally within a service or through external referral. So we know that generally there is a need to embed formal distress screening within routine clinical practice. We have indication from surveys that have been conducted across the UK quite recently that formal distress screening tools aren't often used in clinical practice. We have the work that Barry and Niall discussed earlier, north and south of Ireland, where that bears true as well. We know that's the case. And essentially this is a barrier to optimising psychological services in advanced illness. So it's a barrier because use of formal distress screening tools can help standardise the process to ensure that people are receiving care and also the right level of care as well. So, for example, it's around protecting more specialist support so that individuals with more complex needs can avail of that. So why use a formal distress screening tool rather than just clinical judgment? Well, I'm sure most of us are aware that there is a wealth of evidence around the use of outcome measures generally embedded in routine clinical practice as improving the quality of care. If we look at distress screening specifically, a lot of it is really around equity and unequal access to care. So a more standardised, consistent approach. We know that it improves accuracy and consistency, so there's been quite a bit of work done. I've given an example of quite an early study in this area, but there has been quite a bit of work done that has compared clinicians' judgment to use of short or ultra-short distress screening tools. And essentially, by clinical judgment alone, there is often that under-recognition of moderate to severe levels of distress, and that can be in up to around a third of patients. And it's really because we all rely on informational and emotional cues, and there is a benefit to asking those direct questions, which is what distress screening tools can facilitate. There's also something there as well in terms of improving communications. So I cited a study that I worked with Anne Finucane, our keynote speaker, on a number of years ago. And through that, we were interested in what evidence there is of complexity within referrals into hospices. So we looked at referrals to, I think it was maybe 3 or 4 hospices across the UK. And we find that in that documentation, for the vast majority of individuals, psychological needs were identified as a reason for referral. But the information was very, very scarce. So quite often it was simply stated psychological need, and that was it. And in the focus groups that we conducted, clinicians told us, well, it's easier to evidence physical needs, and it's very hard to quantify psychological need. But actually, there is a lot that we can do to more robustly evidence what an individual's psychological needs are. And that's useful for both referrals within and referrals across settings. So what I'm going to talk about very briefly is one specific formal distress screening tool. Now, there are several that you can choose from that have been validated within palliative and end-of-life care settings. I think just be mindful that some tools generally are brought very quickly across from oncology without having been evaluated for use with individuals with advanced illness. That's something to just be mindful of. This particular measure, quite a few of you will perhaps be familiar with it. So it's the distress thermometer. It's an ultra-short measure, one item. You can see it to the right there. It's essentially a thermometer that goes from 0 to 10. You're asking individuals to indicate over the past week how much distress they experienced, including today, from 0 to 10. At some point as well, you have a clinical cutoff. So depending on the population and how it's been validated, whatever the number is, over that, it would indicate clinically elevated levels of distress that might be indicative of a mood disorder, and that would indicate the need for further assessment. So the distress thermometer, it's quick to administer. It's freely available as well, so you can just download it from the NCCN website. I know it has been integrated within holistic needs assessments in quite a few trusts over in England. There's been a little bit of work done around that here, so it's quite an adaptable tool. And it's endorsed by a number of organisations as well. So what we did between Queen's and Marie Curie, we validated this tool for use in the UK and Ireland. So up until this study, no one had evaluated whether this performs adequately for individuals with advanced cancer in this case in the UK or Ireland. And to do this very briefly, we essentially compared the performance of this one item, ultra short distress screening tool, against a longer distress screening tool, and that's the hospital anxiety and depression scale. We based our analysis on what was routinely collected data. So we did a psychological needs assessment. This was back when I worked at Marie Curie. By the time we were doing this research, I was at Queen's. And we based our analysis on data from 139 patients. And I'm not going to go into the psychometric properties in too much detail here. I don't think anyone deserves that. But very, very briefly, to say that the performance of this one item tool was adequate whenever we compared it to that longer distress screening measure, and adequate in terms of detecting what would be indicative levels of elevated distress that would require further assessment. So that's both in terms of anxiety, depression, and total distress. We also find that a clinical cutoff of at or equal to 5 is what would be recommended for this population as well. So in conclusion, this can be recommended for use in clinical practice. Now, it was due to the data available to us. We have only evaluated for use with individuals with advanced cancers. So there is a real need to look at refining and evaluating the tool to support individuals with both malignant and non-malignant disease as well. There is a lot of further work to be done around implementation. So a tool is just a tool, and what's important is the care that goes around that. So it's around understanding how best to integrate this tool into evidence-based pathways, more broadly around the identification and management of distress. So that's me. If you're interested in this sort of work, feel free to get in touch. So
thank you very much for inviting me here today. So what I'm going to do is I'm going to give you a brief snapshot into the role of the healthcare assistant. Now, I'm very aware I stand between you and the school traffic getting out, so I will be very succinct. And I don't expect any questions, so don't worry. Okay? And I have to say, I'm actually being very disingenuous. Tracey McConnell's name should be up here, Sonia McAfatrick's name should be up here, and Paul Slater's name should be up here. I don't do anything as an I do it as a we. Okay, so apologies, Tracey. Oh, we're going back to distress, folks. Okay. So what is out of hours, and what is the healthcare assistant? Do you know there's no real time for out of hours anywhere in the world? It all varies, and we all know that. But what it means, you just think if you're a caregiver, they're the times where you are absolutely dreading. I know I did. It's the times that represent 63% of the week. And for a caregiver where they don't know who to go, and they think, oh, is this the time? Is this daddy's time to go? Who am I going to call? Is he going to end up in A&E? And that's the reality for many. In the UK, our out of hours times is between 6:30 and 8. But what services do we have for those people who are at the end of life, for those families? The reality is, and I don't need to tell you, you live it, you breathe it, you walk it, you know there's very little. And for those lucky, lucky people who get hospice care, there is support. And who do they have? Well, they have multidisciplinary teams, don't they? You have your specialist nurses, you have your consultants, you have telephone support. But you really have a role called the healthcare assistant, and I'm a real big advocate for this role. Kasia said to me once, and she used this quotation, she said, they're not a specialist, but they're professional. We just don't recognise them. But those who work in this area know they are the bricks and mortar. They're the mortar around all the bricks of what we do, isn't it? So the healthcare assistant internationally, we actually don't have a standard title for them. You know that. We don't have a standard role. They're not regulated around the world. They started off coming in Project 2000, if you remember that. Well, to be honest, they've been here since Florence Nightingale, let's be honest. But really, Project 2000 gave them a really centre stage in nursing. Today, their role is much different from Project 2000. Anybody remember Project 2000? They were there to come in to assist the nurse. What are they doing now? Just think. And they're not trained to any standard nationally. They're not regulated by the NMC. Just think what they're doing. So what are they doing in palliative care? So I did a study looking at, look, what are they doing? What are they doing in the out-of-hour period? And what are healthcare assistants specifically doing? And I spoke to numerous healthcare assistants, and this is a number of studies we've been conducting in this area, and I spoke to a number of carers, active and bereaved. No, I didn't get to speak to patients. Hands up, and although we tried. But we had the ripple effect, and by heavens, we're still living through the ripple effect of COVID, aren't we? Where diagnoses are late. And that's what we found in this study, and it just wasn't right. I wasn't going to ask any patient for take part in a study whenever their time was so precious. So, criticise me, but I know I've been in the right to say no to taking on a patient at that time. So what did we find? So folks, I'm not going to go into the methodology. I want you to hear the findings. Guess what? No surprise. Who's with the patient and the family? It's the care assistant. The reality of how we're operating in hospices is that we're using our specialist practitioners to go in and firefight. They're going in to deal with the problem and they're coming out. And it's the care assistant who's with them. And if you're lucky to have hospice, you have a care assistant who comes in the overnight stay and does a sit. And they come in and they find the caregiver on their knees. How many people have seen a caregiver on their knees? Many of us. And that caregiver, that family member's going, thank God, I can get asleep. Thank God I've left Daddy with good hands. And that means everything. And that means they can continue on. They can continue on caring. They can continue on ensuring that Daddy doesn't have to go into hospital. And they're saving hospital beds. So it's the care assistant then who makes these calls. They're there. They're monitoring the patient. They're assessing the patient. And once the patient's all sorted, guess what they do? The caregiver has a few hours sleep. Can't sleep because they're so used not to sleeping. And they get up. And in the very early hours of the morning, they're making a cup of tea. And a cup of tea's too wet without a biscuit, so they're having a biscuit with the family member. And the family member's talking to them. And the anticipatory grief, as we call it, I call it pure sadness coming out, where you see your loved one dying at home. It comes out, and it's the care assistant who's dealing with it. They're responding to the questions, why is God doing this, if they're religious? Why is this happening to us? Why can we not fix? Or why isn't God taking him now? Why this pain? And they are really emotive questions, aren't they, for anybody? But they're emotive questions, particularly for a care assistant who's not standardly trained. But you know what they have? They have this. They have experience in these. They have what I call common sense, a skill my children don't have. But it's such a valuable commodity. And they have people skills. But care assistants then are the first then to detect if there's a deterioration in the patient. They're not trained. This is all on, I've seen this before, maybe. They're reading cues. They're going, should I change his position? Should I do something here? Is it time to call out of our services? They're left in that dilemma of making that decision. That's some decision to put in an onus of a care assistant, isn't it, really? And sometimes they're going, did I make the right call? There's a moral dilemma we're placing on the care assistant's shoulders. And then whenever they're in that dilemma and they call out the out of hour, they call out the specialist nurse, and the specialist nurse is coming in and thankfully they've sorted everybody out. Who's picking up the after effects? It's the care assistant with the family who's trying to go, it's okay, he's fine. I'm reassuring, I'm not going to leave you, I am here. That's the reality of what happens in the out of hour period. And it's not that the specialist practitioners don't want to be there. They're just so thin on the ground. Someone has to be there to care. So from the caregiver's view, well, whenever I say they were on their knees, they were on their knees by the time they got a hospice care. And they were so thankful they were able to care, but they could not have cared without that input. And it wasn't just pain management they needed. They needed to be recognised as they are a person too, and they are going through this journey. And that's what the healthcare assistant did. So once they got daddy sorted, they then sorted with the family. And the family just wasn't the wife, the daughter. The family was the extended family, where they looked after and they prepared people. They educated people. What does it mean? What are the signs of dying, the last stages? How do you use all these different equipment? And repeatedly embedded those skills into the family member. And were there then to do the counselling and provide that compassionate care and answer those questions that we have no answer for in reality. They also cared for the body after death. Now in the UK, they're actually bringing in care assistants to verify death. There's a pilot study happening at the moment because they cannot get the professionals out. Or the family is sitting waiting. One caregiver told us they had to sit and wait for over 8 hours with the body. And some of you may think that's okay, but for other people that's hard. That's hard to do. So they had to do that, and they also dealt with that grief after it. And many care assistants didn't end with their caring. Many of you know. Where do they go? They attend the wakes. They attend the funerals. And some of them still keep in contact with families because they know the family, know that family still needs support, and they signpost them. So if you look at the spectrum of care that they do, there's many elements of care they do that is unwritten. I have a recommendation. Let's value them. Let's value this role. We're increasingly become reliant on them. The nurse is not by the bedside, and that's not something I'm advocating at all up here, but it's not. We just don't have the numbers, and we have too much demand. And we're placing our demand on our care assistants. And if we are, let's value them for that and recognise them. So thank you so much for your time this afternoon. And hopefully that was able to outline just a bit of my passion for that care assistant role. Thank you.